Hello and welcome back to the Deep Dive. I'm your host, and today we are doing something a little bit different, something I think is very special for the learner out there. If you are a medical student, a surgical trainee, or, just someone who is fascinated by the incredibly complex, sometimes explosive machinery of the human body, this is tailor-made for you.
It certainly is. Usually we take a broad topic and sort of narrow it down, but today we're flipping that. We're taking a physical object, a very specific, very dense piece of literature, and turning it into an audio experience.
Exactly. We are diving headfirst into Chapter 57 of Baily and Love's Short Practice of Surgery, the 28th edition.
The big one.
The big one. The title of the chapter is The Adrenal Glands and Other Abdominal Endocrine Disorders. Now, for anyone who's been through med school, Baily and Love it's basically the Bible of surgery. But Chapter 57, it's notorious.
Oh, it is. It's a heavy read. It is so dense with anatomy, biochemical pathways, genetics, these complex decision-making algorithms. It's the kind of chapter that makes students sweat before they even get near an exam hall.
Right. So our mission today is really clear. We are not just going to read the book to you. That would be boring and, frankly, a waste of your commute or your gym session.
Right.
Our goal is to be your interpretation and revision aid. Think of this as the Ready Reckoner version.
We want to build the scaffolding in your brain. That's the idea. We want to give you the mental hooks and the anchors.
Yeah.
So that when you do sit down to read Chapter 57, and we absolutely want you to read the book.
Oh, you have to read the book.
You have to. But when you do, the concepts will just click into place. You'll say, oh, right, that's the short fuse they were talking about.
We're going to act as your guides through the wilderness. We'll connect the dots between the anatomy you maybe half remember from the cadaver lab, the physiology that explains the patient's really weird symptoms, and then the surgical decisions that actually save lives.
And we've got a roadmap for you. We're going to travel from the salt, sugar, sex of the adrenal cortex down into the explosive world of the adrenal medulla. And finally, we'll head out to the diffuse, almost mysterious world of the pancreas and GI neuroendocrine tumors.
And keep your ears open, because we're going to throw in some check-in questions and a few fictional case studies to test your understanding in real time. We want you to actively participate here.
Let's unpack Chapter 57.
Okay, let's start with the lay of the land. We need to anchor ourselves in the anatomy. In adrenal surgery, anatomy isn't just geography, it's destiny, really.
That's a great way to put it.
So we're talking about the adrenal glands. They're tiny, right?
They're deceptively small. A normal adrenal gland weighs about 4 grams. Just think about that for a second. That's a rounding error on a scale.
4 grams.
But the physiological punch they pack is massive. They sit way back in the retroperitoneum, tucked away within something called Gerota's capsule, surrounded by this protective layer of fat.
And they aren't identical twins, are they? I mean, they don't look the same on a scan, which I always found interesting.
No, not at all. This is what we could call the asymmetry alert. If you're a radiologist or a surgeon, you need to know this cold. The right adrenal gland is pyramidal in shape.
Like a little triangle.
Exactly, like a little triangle or a dunce cap. It's tucked right up behind the inferior vena cava, the IVC, and it sits between the liver and the diaphragm. It's a bit of a hidden spot.
And the left one?
The left adrenal is more crescent-shaped.
Okay.
Semilunar is the technical term. It sort of drapes over the superior medial aspect of the left kidney. It's a little bit lower, and it's covered by the tail of the pancreas and the spleen.
Okay, so right as a pyramid, left as a crescent. That's a good visual anchor to have. Now, here's where it gets really interesting and honestly a bit scary for the surgeons in the audience. The blood supply is, well, it's messy. Arteries coming from everywhere.
Real mishmash.
But the drainage, the venous drainage, is where the danger lies.
Absolutely. This is the danger zone.
Yeah.
If you remember one thing about adrenal anatomy from this entire deep dive, remember the venous drainage. It dictates the safety of the entire operation.
Okay, let's break it down. Left versus right.
All right. The left adrenal vein is, let's call it the friendly one. It's relatively long, and it drains downwards into the left renal vein. It's predictable. You have a bit of room to work, to get your clips on.
You can see it. You can handle it.
And the right adrenal vein is the surgical equivalent of a short fuse on a stick of dynamite. It is incredibly short. We're talking sometimes just a few millimeters.
Yeah.
And it doesn't drain into a tributary. It drains directly into the posterior aspect of the inferior vena cava.
Directly into the main pipeline carrying blood back to the heart.
The main pipeline of the body.
Okay.
Exactly. So when you're dissecting the right adrenal, you are working deep in this dark hole. You're lifting the liver out of the way, and you are millimeters away from the cava. If you pull too hard, you don't just tear the adrenal vein, you can avulse it. You can rip it right out of the wall of the vena cava.
And that would result in just torrential hemorrhage.
Catastrophic hemorrhage. It's a hole in the biggest vein in your body. So surgically, the right side is always the more precarious dissection because of that short, unforgiving vein.
That's a powerful anchor. Right vein equals short fuse. Handle with extreme care. Okay, now let's peel back the layers of the gland itself. We have the cortex on the outside and the medulla on the inside.
Correct. And it's helpful to think of them as two different organs that just happen to be wrapped in one package. The cortex comes from the mesoderm embryologically. It makes up about 90% of the gland.
And the medulla.
The medulla, the center, that comes from the neural crest, the ectoderm.
I love the description of the medulla I read in the notes. It's essentially a bundle of nerves that forgot how to be nerves and decided to be a gland instead.
That's a very, very accurate way to put it. They are chromatin cells that synthesize catecholamines, adrenaline, and noradrenaline. They are part of the sympathetic nervous system, but instead of using synapses to talk to one other nerve, they just dump their chemicals straight into the blood.
A system-wide alert.
A global alert, yeah.
But let's stick to the cortex for a moment. We need a good way to remember the layers and what they produce. This is classic medical school trivia, but it's absolutely vital.
It is. The classic mnemonic is GFR.
Right.
Like glomerular filtration rate from kidney physiology. But here it's for the layers from outer to inner, GFR.
GFR.
And the hormones they produce correspond to salt, sugar, sex.
Okay, let's walk through it. G.
G is for the zona glomerulosa. That's the thin outer layer. It produces mineralocorticoids, specifically aldosterone, so that matches up with salt. It's all about regulating sodium retention and potassium excretion.
Okay. F.
F is for the zona fasciculata. That's the middle, the thickest layer. It produces glucocorticoids, specifically cortisol, and that matches with sugar. It regulates glucose metabolism, the stress response, all of that.
And finally, R.
R is for the zona reticularis, the inner layer of the cortex. It produces androgens, the sex hormones. So GFR matches salt, sugar, sex, from outside in.
Perfect. It's a classic for a reason. Now, there is a physiological nuance here that Baily and Love really emphasizes. The salt layer, the aldosterone part, it doesn't take orders from the same boss as the other two.
Precisely. This is a key point. The sugar and sex layers, the fasciculata and reticularis, they are driven by ACTH from the pituitary gland. The pituitary is the boss.
But the salt layer?
The salt layer, the zona glomerulosa, is largely independent of ACTH. It's regulated by the renin-angiotensin system.
So the kidney is the boss of the salt layer?
Yes, exactly. If your blood pressure drops or you lose salt, the kidney senses this and releases renin. Renin kicks off this whole chain reaction that eventually tells the zona glomerulosa, hey, we're drying out here, pump out some aldosterone to hold on to salt and water.
Which then raises blood pressure. So it's a completely separate command loop. That is going to be crucial when we talk about diagnosing Conn syndrome in a minute.
It is indeed. It's the whole basis of the diagnostic test.
Okay, time for our first check-in question. I hope you're listening closely to that anatomy section.
Here's the scenario. You are a surgical trainee assisting on an adrenalectomy. The consultant, your boss, turns to you and asks, we are removing the right adrenal gland today. Which major vessel are we intimately close to, and why is the venous dissection on this side so much more dangerous than the left?
Take a second. Visualize that pyramid tucked behind the liver. Think about that short fuse.
The answer is the inferior vena cava, IVC. And the reason it's so dangerous is that the right adrenal vein is very, very short, and it drains directly into the IVC. The risk is that a little bit too much traction can tear the vein right off the cava, causing massive, potentially fatal hemorrhage.
Whereas the left side is safer because that vein is longer and drains into the renal vein first.
Much more forgiving.
Did you get it? If not, maybe just rewind a minute. Remember the short fuse.
No.
Okay, moving on to section 2, we're going to talk about the incidentaloma and the disorders of the cortex.
Ah, the incidentaloma. It's a term you hear constantly now. It's really a disease of modern technology.
How so?
We just scan everyone for everything.
Yeah.
You have a car accident, you get a trauma CT, you have some vague belly pain, CT abdomen, and boom, the radiologist's report comes back. 2-centimeter nodule on the left adrenal gland, incidentally noted.
And the patient has absolutely no symptoms related to their adrenal gland, but now there's this lump, and the surgeon's dilemma is, do we take it out or do we leave it alone?
Exactly. And Baily and Love gives us a very clear algorithm for this. We need to answer two main questions. One, is it functional? Is it making hormones it shouldn't be? And two, what's its malignancy potential? Is it cancer?
Let's talk about the cancer risk first. There's a size rule, isn't there?
There is the 4 centimeter rule. It's a general rule of thumb, but it's a good one. Lesions that are less than 4 centimeters are, in general, usually benign.
Okay.
But lesions greater than 4 centimeters have a much higher suspicion for malignancy, either a primary adrenocortical carcinoma, which is rare but nasty, or a metastasis from somewhere else, like the lung or kidney. So greater than 4 centimeters is a flashing red light for surgery.
And what about the look of it on the CT scan? We talk about density. What does that mean?
We use something called Hounsfield units, or HU, to measure density. And really what we're looking for is fat. Benign adenomas are full of cholesterol and lipids to make hormones. They're fatty.
And fat is less dense.
Right. Fat is less dense than muscle or a cancerous tumor. So a benign tumor will have a low density on a non-contrast CT, typically less than 10 Hounsfield units.
Less than 10 is likely benign. Got it.
Correct. And we also look at washout. If you give IV contrast dye, a benign adenoma, which has a healthy, organized blood supply, will take up the dye and then wash it out very quickly. A malignancy, on the other hand, tends to hold on to the contrast. It has what we call delayed washout because its blood vessels are all chaotic and leaky.
So if it's big, over 4 centimeters, or if it's dense, over 10 HU, or if it holds on to dye, we worry.
We worry.
Okay, now let's talk about the functional side. The salt, sugar, sex going haywire. Let's start with Conn syndrome.
Primary hyperaldosteronism. This is the salt layer acting up, and overproduction of aldosterone.
I like to call this the canary tumor.
Oh, why is that?
Because the textbook describes the aldosterone-producing adenoma as being small, usually less than 2 centimeters, and macroscopically, when you cut it open, it's a bright golden yellow, like a canary.
That's that lipid content we were just talking about. That bright yellow color is all the cholesterol. So clinically, what does this patient look like? How do they present?
They present with the classic combination of hypertension and hypokalemia, which is low potassium.
The anchor here is pressure in P's. The high aldosterone causes sodium and water retention, which drives up the blood pressure. That's the pressure.
And the P's.
And it causes potassium dumping in the kidneys. The low potassium disrupts the kidney's ability to concentrate urine, leading to a condition that mimics diabetes insipidus. So they have polyuria. They pee a lot.
Pressure and P's. I like it. And how do we diagnose it for sure?
The key test is the ARR, the aldosterone-renin ratio. In Conn's, you have this tumor autonomously pumping out high levels of aldosterone. But the body's trying to compensate, right? So the renin level is suppressed. It's very low. A high aldosterone with a low renin is the hallmark.
Now, here's a really important nuance. You mentioned in our prep that if the patient is older, we can't just trust the CT scan. Why is that?
This is a classic trap for the unwary. As we age, our adrenal glands get lumpy. It's called nodular hyperplasia. So an older patient, say 60 years old, might have the high aldosterone and low renin, and a CT scan shows a lump on their left adrenal gland.
So you think, great, that's the one.
You'd think so. But that lump on the left might just be a non-functioning incidentaloma, and the real problem could be a tiny area of hyperplasia on the right side that's too small to even see on the CT.
So if you take out the left one,
You've done a pointless operation. You've removed the wrong gland. The patient still has high blood pressure, and now they're down one adrenal. That's why in patients over about 35 or 40, we often use adrenal vein sampling, AVS.
what does that involve?
An interventional radiologist puts catheters into the adrenal veins on both sides to measure the aldosterone levels coming directly from each gland. It's the gold standard to confirm which side is the culprit before you operate.
That is a critical safety step. Don't guess, measure.
Okay, moving from salt to sugar. Cushing syndrome.
Hypercortisolism. Too much cortisol. A really debilitating condition.
The visual mnemonic here is unforgettable. It's the lemon on sticks.
It's so vivid, isn't it? It perfectly describes the body habitus. You get central obesity, the lemon where fat deposits on the trunk, the face gets round like a moon, and you get a buffalo hump on the back of the neck.
But at the same time...
At the same time, cortisol is a catabolic hormone. It causes protein breakdown and muscle wasting. So the arms and legs become very thin, the sticks, lemon on sticks.
It's a striking image. Now, the diagnostic dance for Cushing's is tricky because you have to figure out where all this extra cortisol is coming from.
Right. You have to ask, is it ACTH dependent or ACTH independent? Remember, ACTH from the pituitary is the manager and the adrenal gland is the worker.
So if the pituitary manager is screaming, sending out tons of ACTH, that's Cushing's disease. A tiny tumor in the pituitary is pumping out ACTH, overstimulating both adrenal glands. In this case, the patient's ACTH levels will be high or inappropriately normal.
And what if the adrenal worker goes rogue and just starts making cortisol on its own?
Well, if an adrenal adenoma or carcinoma is pumping out cortisol all by itself, the negative feedback loop kicks in. All that cortisol tells the pituitary to shut up, so the ACTH levels will be suppressed very, very low.
So checking the ACTH level is the key branching point. High ACTH points to the brain, or sometimes an ectopic source like a lung cancer. Low ACTH points directly to the adrenal gland itself.
Precisely. It's the most important step in the workup.
Before we leave the cortex, we have to mention the scary one, adrenocortical carcinoma, ACC.
It's rare, but it's very aggressive. These are often huge tumors when they're found. They present late and often with a mixed picture, maybe some Cushing symptoms plus virilization, hair growth, a deep voice in women because the tumor is just chaotically secreting multiple hormones.
The text mentions the Weiss criteria. What's that?
That's the histological checklist. After the tumor is removed, the pathologist looks at it under the microscope and scores it based on features like high mitotic rate, necrosis, invasion into the capsule. You need a certain score to officially call it malignant.
And there's a specific drug mentioned for this, right? It sounds like an insecticide.
Mitotane. It's an adrenalytic drug. It essentially chemically destroys adrenal tissue, both cancerous and normal. It's used as an adjuvant therapy after surgery for ACC.
Okay, let's try to solidify all this cortex stuff with a fictional case study.
Let's do it.
Meet Sarah. She's 34 years old. She comes to her GP because her blood pressure is stubbornly high, like 160/95, and she just feels weak. Not tired, but weak, like I can't climb the stairs weak.
Okay, stop right there. A young patient with resistant hypertension and muscle weakness. That triad is already screaming Conn syndrome, pressure and P's. The weakness is the hypokalemia.
Exactly. The GP does a blood test. Her potassium is 2.8, very low. So a CT scan is ordered. It shows a 1.5 centimeter nodule on the left adrenal gland, and the report notes it's lipid-rich.
So we have the biochemical picture and the anatomical target. Now here's the key question for you, the listener. Does Sarah need adrenal vein sampling?
What do you think?
Because she is young, under 35, and the clinical and radiological picture is so crystal clear, the guidelines would suggest you can probably skip the AVS. The likelihood of a random, non-functioning incidentaloma in a healthy 34-year-old is very low. You can proceed to surgery with high confidence.
And the surgery would be?
A laparoscopic left adrenalectomy, a keyhole operation to remove the left adrenal gland. And if it is indeed a Conn's adenoma, there's a very good chance her hypertension will be completely cured.
A potential cure for high blood pressure. That's huge. Okay, fantastic. Now let's go deeper into the medulla, the adrenaline rush.
Now we're talking about phaeochromocytoma, PCC, and paraganglioma, PGL, the catecholamine-secreting tumors.
Okay, first things first. What's the difference? I always get them a bit mixed up.
It's all about location. A phaeochromocytoma is a tumor of the adrenal medulla itself. It's inside the adrenal gland.
Got it.
A paraganglioma is a tumor of the extraadrenal paraganglia. This is sympathetic nervous tissue that can be found anywhere along the aorta, in the bladder, even up in the neck and the base of the skull.
Okay, so PCC is in the gland. PGL is outside. Now, in medical school, we all learned the rule of tens for pheo. 10% malignant, 10% bilateral, 10% familial. Baily and Love basically says, scratch that old rule.
Yeah, that rule is really outdated, specifically the 10% familial part. With modern genetic testing, we now know that up to 30%, maybe even more, are familial or have a genetic basis.
That's a huge jump from 1 in 10 to almost 1 in 3.
It's a massive shift in our understanding. It means if you find a pheo, you absolutely have to think about genetics and screen the family.
So we need to know the alphabet soup of genes involved?
You do. It's important for screening for other tumors. We have MEN2, which is caused by a RET mutation. We have VHL, von Hippel-Lindau disease that's associated with retinal angiomas and renal cell cancer. We have NF1, neurofibromatosis, the café au lait spots, and then the SDH mutations, which are strongly associated with paragangliomas and a higher risk of malignancy.
Okay, so what about the symptoms? How does a patient with a pheo present?
They present with a classic triad: headache, sweating, and palpitations. And the key is that these are often episodic. They come in spells.
So the patient feels fine, and then suddenly
they're hit with this pounding headache. They're drenched in sweat. Their heart is racing out of their chest. They feel this overwhelming sense of doom, like they're going to die. It's a terrifying experience.
And this leads us to arguably the most important surgical safety anchor in this entire chapter. If you are going to operate on a pheo, there is a golden rule about the drugs you use beforehand.
Alpha before beta.
Say again, it's that important.
Alpha blockade before beta blockade. You must never, ever, under any circumstances, start a beta blocker before you have established a complete alpha blockade.
Okay, unpack that. Why is it so incredibly dangerous?
Let's use a simple plumbing metaphor. Your blood vessels are pipes. Your heart is the pump. The tumor is flooding the system with adrenaline and noradrenaline. These chemicals hit two types of receptors: alpha receptors, which squeeze the pipes shut, that's vasoconstriction,
Okay.
and beta receptors, which speed up the pump and make it beat harder. So you have a racing pump trying to force blood through squeezed pipes. That's why the blood pressure is so high.
Right. The pump is racing and the pipes are squeezed tight.
Now, if you give a beta blocker first, what happens? You block the beta receptors on the heart, you slow the pump. But you've done nothing about the alpha receptors. They are still screaming, squeezing the pipes as tight as they can.
So you get what's called unopposed alpha stimulation.
Exactly. The pipes are clamped shut, and now the heart is chemically hobbled, struggling to beat against this massive, impossible resistance. You can precipitate a hypertensive crisis, acute heart failure, and flash pulmonary edema. You essentially blow up the plumbing.
It's a disaster.
A complete disaster. You must give an alpha blocker first, something like phenoxybenzamine, for 10 to 14 days to relax the pipes, widen the pipes. Only then, once the pipes are open, is it safe to give a beta blocker to gently slow the heart rate down.
That is such a critical life-saving concept. Alpha before beta. Open the pipes before you mess with the pump.
Before we leave the medulla, we should probably give a brief mention to neuroblastoma.
Right. The pediatric tumor.
Yes, the most common solid extracranial tumor in children. It's a tragic disease. A key marker that Baily and Love mentions is MYCN gene amplification. If a child has that marker, it unfortunately predicts a much poorer prognosis.
Okay, let's do check-in question 2. This one is a real test.
Imagine you are on the ward. A patient with a known phaeochromocytoma is being prepared for their operation. The intern, who's keen but new, notices the patient has a heart rate of 120 and says, "Oh, I'll just give him some beta blocker to bring that down." You instinctively grab the intern's hand and say, "Stop." Why?
Think about the pipes in the pump. What did we just discuss?
The answer is because of the risk of unopposed alpha stimulation. If you block the beta receptors on the heart first, the alpha receptors on the blood vessels are left unchecked. The vessels will constrict violently, causing a catastrophic hypertensive crisis and acute heart failure. Always alpha blockade first, then beta.
You just saved a fictional patient's life. Good job. All right, let's leave the adrenals behind for a moment. We are moving to what the book calls the diffuse neuroendocrine system. We're heading to the pancreas and the gut.
Right, the so-called APD cells. These are scattered endocrine cells that are not in one discrete gland. Let's focus on the pancreatic neuroendocrine tumors first, or PNETs.
And the most famous one, the one everyone learns about, is the incidentalomas.
Right, a tumor that secretes insulin. And too much insulin, of course, causes hypoglycemia, dangerously low blood sugar.
And there's a classic triad for this one too, isn't there? Whipple's triad.
Yes, and it's important not to confuse it with the Whipple surgical procedure. Whipple's triad is purely diagnostic. It has 3 parts.
Okay.
1, the patient has symptoms of hypoglycemia, like confusion, sweating, fainting, usually brought on by fasting or exercise. 2, you have to document a low blood glucose level at the time of the symptoms. And 3, the symptoms are rapidly relieved when you give the patient glucose.
If you satisfy those 3 criteria, you've pretty much diagnosed an insulinoma. And these are usually benign and solitary, right?
Yes, over 90% are benign and can be cured with surgery.
Now let's talk about the flip side. Not low sugar, but too much acid.
Yeah.
The gastronoma.
Also known as Zollinger-Ellison syndrome. In this case, the tumor pumps out a hormone called gastrin, which tells the stomach to produce acid. And not just a little acid, buckets and buckets of acid.
So these patients present with just terrible, recurrent peptic ulcers, often in unusual places like the jejunum.
Exactly. Refractory ulcers and often chronic diarrhea. Now, the surgical challenge is, where do we find these tumors? They can be tiny and hard to locate. But there's a very specific anatomical map called the gastronoma triangle, or Pissarro's triangle.
Can you visualize that triangle for us? Where is it?
Sure. Imagine drawing 3 points in the abdomen and connecting them. Point 1 is the junction of the cystic duct and the common bile duct up near the liver.
Okay.
Point 2 is the junction of the second and third parts of the duodenum. And point 3 is the neck or body of the pancreas. About 90% of gastronomas are found hiding within this so-called magical triangle.
That's a fantastic visual for a surgeon who's exploring the abdomen looking for one of these things. Now, what about the GI nets, the gastrointestinal neuroendocrine tumors? We used to call them carcinoids.
Right. These are most commonly found in the appendix, often as an incidental finding after an appendectomy, and in the small bowel. Now here's a fascinating physiological concept you need to grasp: carcinoid syndrome.
This is the flushing and diarrhea.
The flushing, the diarrhea, the bronchospasm, yes. But, and this is a really big but, you generally do not get carcinoid syndrome from a primary tumor that's just in the gut.
Why not? The tumor is still secreting all those vasoactive substances like serotonin, isn't it?
It is, but all the blood from the gut goes through the portal vein straight to the liver, and the liver is a master detoxifier. It metabolizes and breaks down almost all of that serotonin before it can get into the systemic circulation and cause problems.
So the liver protects you. It acts as a filter.
Exactly. You only get the classic carcinoid syndrome if the tumor has metastasized to the liver. Once there are tumor deposits in the liver, they secrete serotonin directly into the hepatic veins, which bypasses the liver's filtering mechanism and goes straight to the heart and the rest of the body.
That is such a key concept to understand. Liver mets equals the syndrome. No liver mets usually means no syndrome. That's a great takeaway. And the text mentions something called a desmoplastic reaction with these tumors. What's that about?
Yes, this is a hallmark of small bowel nets. These tumors release substances that cause an intense fibrotic reaction scarring in the mesentery, which is the fatty tissue that holds the intestines. On a CT scan, it can look like the spokes of a wheel radiating out from the tumor.
And that can cause problems.
Big problems. That scarring can shrink and retract, kinking the bowel and causing an obstruction. It's a very characteristic finding.
Spokes of a wheel. I like that image. Okay, section 5. We need to put all of these disparate tumors together. Let's talk about the MN syndromes, multiple endocrine neoplasia.
Right. This is where you get constellations of these tumors because of a single underlying genetic mutation. It's alphabet soup territory, so we need strong anchors to remember them.
Let's start with MNN1. That's Vermeer syndrome. The mnemonic for this one is pretty easy. It's the 3 Ps.
The 3 Ps. That's all you need to remember.
Okay, what are they?
First P is parathyroid. Hyperplasia of the parathyroid glands is the most common feature, seen in over 95% of cases. It causes high calcium.
Second P.
Second P is pancreas. These are the peanuts we just talked about. Gastronoma is the most common, followed by insulinoma.
And the third P?
The third P is pituitary, usually a prolactinoma, a tumor secreting prolactin. So parathyroid, pancreas, pituitary. The 3 Ps, the gene is the MEN1 gene.
Simple enough. Now for M2, this is all about the RET proto-oncogene.
The RET gene is the key. And there's a 2A and a 2B. What do they have in common?
They both have medullary thyroid cancer, MTC, and phaeochromocytoma.
That's the core of MN2. And the medullary thyroid cancer is the really crucial one. It is almost guaranteed to develop in these patients. It's a question of when, not if.
So much so that we do prophylactic surgery. We take the thyroid out before cancer can even develop.
We do. In patients with high-risk RET mutations, like an N2B, the thyroid often comes out in infancy. In others, maybe by age 5. It's a very aggressive approach, but it's life-saving because MTC is almost inevitable.
That is heavy. So MN2A is MTC, pheo, and the A as hyperparathyroidism as well.
Right. So MN-PH, medullary pheo hyperparathyroidism.
And MN2B, what's different there?
MN2B is the more aggressive variant. You have the MTC, which is very aggressive, and the pheo. But instead of parathyroid issues, you get a characteristic physical appearance. A marfanoid habitus, they're tall and thin, and mucosal neuromas, which are these little bumps you can see on their lips and tongue.
Okay, let's try to apply this with our fictional case study too.
All right. A young patient presents to the emergency room with kidney stones. The workup finds they have hypercalcemia, high calcium in their blood.
Okay, kidney stones, hypercalcemia. My brain immediately goes to parathyroid.
Good, it should. But then you take a detailed family history, and you find out that an uncle had severe ulcers that were really hard to treat, and a cousin had a distinct pituitary issue.
Okay, wait a minute. Stones means parathyroid. The uncle's ulcers sound like a gastronoma, which is pancreas. And then there's a pituitary issue. We have the 3 Ps.
Bingo. This screams MN1. The gene you'd want to check is the MEN1 gene on chromosome 11. It connects all the dots.
We are entering the final stretch now. Section 6, adrenal emergencies. Because sometimes the adrenals just quit.
Right. This is Addisonian crisis or acute adrenal insufficiency. And this is a true medical emergency.
What triggers it?
Usually it's a patient who has known chronic adrenal insufficiency, Addison's disease, who then faces a major physiological stress like sepsis or major surgery, or someone on long-term steroids who suddenly stops taking them. They just can't mount a cortisol response and they crash.
They go into shock.
Profound shock. Hypotension, hypoglycemia, confusion, they can dive very quickly.
The text also mentions a really dramatic version of this called Waterhouse-Friderichsen syndrome.
That is bilateral adrenal hemorrhage, usually due to a severe, overwhelming sepsis, classically meningococcal sepsis. Glands basically explode from bleeding. It's catastrophic and almost always fatal.
So, the rescue. A patient is in front of you, in shock. What do?
You do not wait for test results. You act immediately. The treatment is IV fluids liters of normal saline to treat the shock and IV hydrocortisone. A big dose, right away. You have to replace the cortisol they're missing.
Resuscitate and replace.
That's the mantra.
We have covered a massive amount of ground, from these tiny 4-gram glands all the way to the complex genetics of the MN syndromes. Let's bring it all home. What are the absolute key anchors the learner needs to walk away with from this deep dive?
Okay, let's recap the ready reckoner points, the big takeaways. Number 1, anatomy. The right adrenal vein is short, it drains to the IVC, and it is danger.
Remember the short fuse.
Number 2, physiology. Remember the cortex layers are GFR, and the hormones are salt, sugar, sex. Number 3, phaeochromocytoma. The mantra is alpha before beta. Always open the pipes first.
Critical.
Number 4, MNN1. That's easy. The 3PS parathyroid, pancreas, pituitary. And number 5, MNN2. It's all about the RET gene and the near certainty of medullary thyroid cancer.
And I'd add the 4-centimeter rule for incidentalomas. It's a simple but effective first step.
A very good one to add. And maybe one final provocative thought to leave you with. The chapter mentions the future of diagnostics, and this idea of liquid biopsies is really taking off. Imagine, in the future, being able to diagnose and monitor these complex neuroendocrine tumors just by analyzing fragments of circulating tumor DNA in a simple blood test, skipping the need for invasive tissue biopsies entirely.
Precision medicine without the needle. That's a fascinating place to end. To our listeners, our learners, remember, this was the map. Baily and Love, Chapter 57, is the terrain. Now you have the framework, so open the book, go look at that gastronoma triangle diagram, reread the algorithm for the incidentaloma.
Build the scaffold, then fill in the bricks. That's how you learn it for good.
Thank you so much for diving deep with us today. Stay curious and keep diving deep.
Goodbye.